I had a childhood stutter, so I had the experience of having a symptom which it wasn't caused by a disease, but it was still something that affected what I could do. So I think that gave me a bit of an insight. And then when I started to meet patients with it, I just found it, amongst other things, it was just really fascinating. You know, why does someone have a weak leg or a tremor or a seizure? And the kind of explanations people were coming up with just didn't seem sufficient to me. You know, they were saying, well, it's stress, or they've converted a stress. And I think, well, how did that cause a weak leg? So there was a sort of intellectual side to it as well, but also combined with just thinking the way that the patients are being treated just isn't, you know, this can't be right, that the patients with diseases are being believed and treated as best you can, even if it's difficult to treat them, and these patients are just being dismissed and saying, no disease, goodbye.
I did the combined residency at Brown University in neurology and psychiatry. In the 5th year of my residency, I was at an epilepsy conference, and they talked about how complex these patients are and how difficult they are to treat. And the statement was, all right, now the diagnosis is pseudo-seizures and the treatment is they're really complex and they need a psychiatrist. Now let's move on to the next subject.
There's a sort of conceptual problem, I think, that many doctors have about what their job is. I think they're sort of schooled to believe that their job, that the body is a machine, their job is to find disease and treat it, and if it's not a disease, maybe that isn't their job, particularly in some specialties. Whereas I think our job as doctors is to relieve suffering and treat symptoms, and if they happen to be caused by a disease, then that's fine, but there's many causes of symptoms.
When we do our assessment, so because I do neurology and psychiatry, I do a comprehensive neurologic and a comprehensive psychiatric evaluation in the time that I have with the patients. Look over all of the records, the many prior consultants that they've seen, the multiple tests, and try and put all that together. When we do that comprehensive evaluation, we found that about 5% of people don't have some other type of psychological factor. And I'm not saying that that's the causation of their event, but it's one of the risk factors. So whether it's a childhood adverse event, whether it's a history of trauma or abuse that happens in some but not in everybody, or a neglectful household, or some type of recent event, or comorbid depression or anxiety. Those are commonly found in this population, and it's important to address those along with this presenting symptom, whether it's a seizure or a movement.
Doctors have come up with lots of creative excuses not to be involved with this problem. And for neurologists in particular, that's a common excuse is, well, I don't need to worry too much about this because A, it's not a brain disease, and B, they're probably exaggerating. But how bad is it to think that someone is exaggerating when they're not? How much of an error is that as a professional?
It's when we put the neurology and the psychiatry together, and when we look at it from a brain-mind perspective, looking at the whole of the person, I think that's where we can have the strongest voice for the patient.
If you're coming along to this problem and saying, no, I just only believe in conversion hypothesis and they've all got conversion disorder, or I'm only going to use a cognitive behavioural model, I certainly wouldn't be happy. You know, I'm not happy with that. I think this requires all kinds of perspectives, and that for me is one of the things that makes it interesting. All of these things are at the same time relevant.